Now we have 3 small molecule inhibitors. We have Ibrutinib, we have Idelalisib, the PI3K inhibitor, and now we have Venetoclax, the BCL2 inhibitor. In general, I think the preference is to use Ibrutinib first, and in fact, Ibrutinib is the only drug that actually, of the 3, has a frontline indication. So that is the one that mainly is going to be used first. Then the question becomes, what about the PI3K versus the BCL2? Last year, Anthony Motto and colleagues published data. It wasn't trial data, but basically about 10 centers got together and pooled their data for what happened when they switched a patient with CLL from one kinase inhibitor to another. So either Ibrutinib to Idelalisib, and that was the main direction. So most of the data was looking at that. And then there was a not as great size cohort of patients who had gotten Idela first in the relapse setting and were switched over to Ibrutinib. And what they showed is that if you switch the patient over because of intolerance, they did fairly well. But if you switch them over because they were truly refractory to the first kinase, the median progression-free survival was 7 months. So you get some effect, but it didn't appear to be very durable. In contrast to that, there is a trial that was presented at ASH last year looking at Venetoclax specifically in patients failing Ibrutinib or Idelalisib. And what that trial showed was that the 12-month progression-free survival for those patients was 80%. So I think based on that data, it's very clear that if you have a patient who fails a kinase inhibitor, it's better to switch to Venetoclax. Do we have any data for people who've gotten Venetoclax and then switched to Ibrutinib? Very, very little, because Venetoclax came along much later. But the original Venetoclax studies, which were being done in Australia, for example, the phase 1 paper that was published in the New England Journal last year, those patients had never seen a BTK inhibitor because of when that trial started. So they recently published a paper with a very small number of patients who had been on that trial and then progressed off Venetoclax and received Ibrutinib, and some of them responded, but the number's so small that we don't really have a feel for, in the long run, it appears to be easy to go from a kinase inhibitor to Venetoclax and get very good results. Will the reverse be true? Don't know that yet, and of course Venetoclax doesn't have a frontline label yet either. So for the time being, it's going to be sequenced after almost certainly Ibrutinib, and whether in the future that'll change. Of course, the interesting thing is there are many abstracts at ASH this year on combining Ibrutinib and Venetoclax with or without an antibody. I would say that in general, all of them look very promising with very high MRD negativity rates and no increase in toxicity over what you would see, I would say, with each single agent. So then the question becomes, if the combinations ever actually become approved, and this is very early days, then what's the sequencing? Because you're using both drugs together, and if a patient becomes resistant, will they actually be resistant to both of the drugs? So it's hard to say, but for right now, I think the usual sequencing would be after a B-cell receptor inhibitor, it's preferential to move to Venetoclax rather than to the other inhibitor.